directed my presentation on bicipital tendonitis. The objectives we're going to cover, we're going to understand the characteristics of tendonitis, identify the possible causes for this particular pathology, and we're going to examine the signs and symptoms that they would present in the clinic. We're going to determine the appropriate tests to utilize and how to differentiate between similar diagnoses. And we'll discuss a very broad, because tendonitis is a very individual, specific and dependent pathology. So we'll discuss a very broad plan of care and timeline for that. I know this isn't the greatest picture, but these are just kind of get a visual before we start. There are a lot of tendons running in this area. The shoulder is arguably the most complex joint in the human body, so we have to take proper care when determining which pathology it might be. Tendonitis in general is characterized by inflammation of the tendon and acute micro tears in the musculotendinous junction. It's a pretty common diagnosis in terms of painful syndromes, but it can be easily confused with tendinosis, which we will discuss shortly. Bicipital tendonitis in general is often seen in overhead athletes or workers that possibly lift stuff over their head a lot. Also people that may have a hobby like painting, where they're lifting their arm over their head all the time and possibly like quickly loading it or just lifting something heavy in general over their head. But they often describe this, and we'll talk more about this, as a hot and burning pain over the bicipital groove in the shoulder. So the pathomechanics, or the cause, acute overloading of the musculotendinous junction. If loads are too heavy or too sudden for the tendon to handle, this is where you'll see those micro tears, and it'll just occur, like it'll just be just enough of a tear to induce the inflammation process, and you possibly see a little bit of swelling, warmth in that area. And it can oftentimes, like I said earlier, be confused with tendinosis, but tendinosis is more of a chronic repetitive injury that possibly this person was doing this motion over and over and over again and wasn't given the proper rest to recover from what they were doing. And it's more of a degenerative disease more than acute tearing. But how it presents in clinic, the clinical manifestations, it's anterior shoulder pain. They'll come in and they'll say, you know, when I reach up, that's how I reproduce these symptoms. Sometimes pain radiating down the arm. Sometimes they'll talk about a clicking or popping that could happen if possibly there's slight subluxation. They have pain at night. Functional limitations, they have trouble with, well, not trouble, they're limited in arm elevation, like flexion, scaption, abduction, just anything overhead. They're able to hold resistance, it's just painful. And we'll talk about in a second. You can see when you're doing your test, you possibly see empty infields because of the pain they're experiencing once they reach a certain degree of flexion or abduction or scaption. They have difficulty, what we talked about in class, like the functional movements and the important degrees to do a certain motion. They would have trouble getting their arm behind their head and doing anything too overhead. They might be able to put stuff on shelves. They might be able to still comb their hair. They might still be able to eat. It's dependent on the person, but that would probably be more indicative of rotator cuff versus bicipital tendonitis. The tests and measures, we'll do our special tests, of course, speeds, where we'll flex the shoulder to 90 and fully supinate and give a downward force against their upward force. And the test would be positive if we reproduce their symptoms. Yergeson's, where we have 90 degrees of flexion and forearm pronated, and they give a resisted supination. Same positive signs if it's pain or possibly even subluxation of the long head of the bicep. Uppercut, which is a relatively newer one, the shoulder and neutral elbow flexed to 90, forearm supinated, and they're bringing their fist up to their chin against resistance, and it's the same positive signs. But then palpation, just a note, the bicipital groove where you would be palpating for this becomes a little more accessible with slight internal rotation, just for clinical purposes. But you would often see tenderness in this area and pain with palpation, doing passive range of motion. If active range of motion is incomplete, like I said earlier, you could likely see an empty infield with this particular dysfunction. Goniometer measurements and more so muscle-specific tension testing will be what we'll do with tests and measures, because like I said earlier, strength will probably still be there and holding against resistance will probably still be there. It'll just be painful, and we can mark that with muscle-specific tension testing. So differential diagnosis, like I said at the start, this is a very complex joint. There's a lot of different things that might present the same way in clinic, like superior labrum or just labrum tear in general. It would be acute onset, similar to tendonitis. The hallmark for that, for labrum, would be the locking and the popping, though, that you wouldn't necessarily see with bicipital tendonitis. But you can do clunk test, which is supine, one hand on the posterior aspect of the humeral head while the other hand holds the elbow. Well, the humor is proximal to the elbow, and the clinician fully abducts and pushes anterior to the humeral head while the other hand externally rotates. And that clunk, like in the test name, that should be the clunk-like sensation that you might feel if like a labral fragment has found its way into the glenohumeral space. Rotator cuff tendinopathies present very similar to this because they're all right there in that region. So it's very important, but locally testing has been shown to be very sensitive to this and can give us accurate readings if we're diligent in our testing periods. Doing dropping sign, 90 degrees of flexion and max external rotation, and if they cannot hold that test position, you know, they could be showing signs of, for that particular testing for spinatus, but you can see dropping sign in multiple different tests. Empty can for supraspinatus. The subacromial impingement, this one could present, if you're not careful, like the bicipital tendonitis. That one less so than the other two, but you still see that localized pain close to the area of what bicipital tendonitis would look like. But you can do painful arc test where you abduct, and if patient reports pain within 60 to 120 degrees, which is the earlier degree mark, then they could possibly have subacromial impingement. So this is the rough timeline. This is very patient dependent, but in the maximum or the max protect phase, about 0 to 2 weeks, you would be doing a lot of pain modulation, passive and active assist range of motion, isometrics in multiple different planes, and working on that scapulothoracic mobility. Controlled motion or moderate protection phase, about 2 to 5 weeks. Mobilization with movement exercises, maybe have a band at the glenohumeral head pulling inferiorly and posteriorly to aid with glenohumeral flexion. PNF patterns, strength and stability training, and focusing on mobility challenges if you weren't able to get full range motion. Then the return to function and minimum protection phase, progress those strength and stability training using different energy systems, doing plyometrics, more functional movements, getting them back to whatever they came in the clinic saying they weren't able to do. Eccentric loading and endurance training to get back to their day-to-day ADOs. So some of the outcomes, again, this is very dependent on stuff like age, compliance, comorbidities, the degree of their tearing. But typically this is about an 8-week recovery time with non-operative interventions to get them fully returned to function, but their exercises will continue throughout, and patient education is important to prevent whatever it was that caused the acute loading that gave them tendonitis to begin with. Some individuals choose arthroscopy. I found a little bit about it researching. This could actually lengthen recovery time, but a lot of people come back and say they had good experience with having an arthroscopy done. They might elect to do this if they go to physical therapy for a little bit, or maybe the pain's just too hard and they automatically think surgery. There's an intertubercular sheath that covers the long head of the biceps tendon. Some people have that shaped down because it thickens with this disease sometimes, depending on severity. And some people, this is more for tears, but they'll actually remove the long head of the biceps tendon from the glenoid labrum and actually screw a hole in the humerus and anchor it into the hole. And this could lengthen it to like 4 or 6 months of recovery, because they would have to be immobilized for a short period. But an overview of what we went over: bicipital tendonitis is characterized by the hot and burning pain over the bicipital groove that's worsened with overhead movements, and it is caused by acute overloading, whether that be weight or velocity dependent on the long head of the biceps tendon. It requires diligent examination with special tests, range of motion, MMTs, and muscle-specific tension testing, and palpation typically resolves within 2 months with proper intervention. These are my references.